Hello, and thank you everyone for coming today. I'm Adrian Park, I'm Chair of the Chemical Pathology CCT, and we'll be presenting the ChemPath curriculum update today from Royal College of Pathologists. And our presenters today will be myself, there'll be Dr. Andrew Hutchesson, who was the previous Chair of the CSTC and who was very much involved in writing the new curriculum. And also from RCPath, there'll be Joe Brinklow, Jenny Maganley, Laura Morrow and Sandra Dura-Crichton. Please be aware that, all your cameras and microphones and chat function are disabled for the duration of the webinar. You should be aware of the QA function, which allows them to ask questions throughout the webinar and to upvote questions they would like to see answers. All questions will be addressed at the end of the webinar, and a record of the Q&As will be made available on the website after the event. You need also to be aware that the webinar is being recorded, but that actually you are not visible in any way. The aim is that the recording will be on the website after the event too. All the curriculum and supporting documents will be emailed to you all after the meeting, and everything will be made available on both college websites shortly. During the meeting, when the first presentation begins, all cameras and mics will be switched off with the exception of the presenter. Okay, shall we begin?
Well, good morning, everybody, and thank you, Adrian. I've been asked to talk about the curriculum development and assessment, and if I could have the first slide, please. This really started from 2013, when the Greenaway report on the shape of training was published, and this was backed up in 2017 by a GMC document on the structure of curricula, a generic professional capabilities framework. Next slide, please. The main thrust of the Greenaway report was to develop a generalist physician who was able to change careers possibly during his career and develop special expertise in various subjects. And so we have here, for example, an emphasis on flexible learning, an emphasis on building a generalist. It was suggested at one stage that there should be as few as 8 specialties, and a thrust to move specialist knowledge into a series of credentials which could be taken following acquisition of the CCT, and a suggestion that subspecialties should be changed to these credentials. Next slide, please. Following this, the GMC's Generic Professional Capabilities framework was published in May 2017. This built on shape of training, but it also had concern that there were a lot of specialties, 67 in all of which had different curricular structures, often seeking to develop a large number of assessments. But the cases that came to the GMC on professional issues were largely about generic issues. And based on this, they wanted to develop a generic curriculum which could be, or generic structure for a curriculum, which could be applied to everything. And you see this on the left with 3 main domains: knowledge, skills, and values and behavior, and then 4 other areas which cross-cut all of those. And you may recognize from the first 3 domains Miller's prism, which was also divided into attitude, skills, and knowledge. And rather nicely, our previous curriculum was also structured in this way. Next slide, please. So the GMC wanted curricula to have a smaller number of high-level learning outcomes with holistic assessment of trainee progression based on expert supervisor trust assessment. They wanted a progression grid which showed how trainees were progressing through the curriculum, and they wanted it mapped to that framework that I have just shown you. And they wanted all curricula to be rewritten in line with this, and for this to be completed and introduced by August this year for all curricula, or specialist curricula. Foundation curricula and basic specialty training, of course, would have to be introduced progressively earlier, and has been so introduced. Next slide, please. They laid out a structure by which the curriculum would be developed, and this was a two-stage process. The first was a curriculum oversight group, which had input from 3 areas, all with different agendas. The first of these was the GMC, which was interested in standards. Then there was an input from Shape of Training, seeking to achieve that. And the third was input from the service providers and the educators, such as Health Education England. And I've put the particular interests of these 3 agendas as they impacted us. Shape of Training, the need to provide flexibility, and the question of the tension between credentials and subspecialties. And service oversight, the requirement to prove a case for the need for the specialty, and a wish to limit the duration of training as much as possible, both from the point of view of speed of getting trainees through to independent practice, and to limit the cost. So the curriculum oversight group would confirm a need for the curriculum, and the idea was that the college would then develop the detailed curriculum, and this would be assessed by the curriculum advisory group, which was run by the GMC and was basically assessing the standards of assessment. Okay, next slide, please. So the first question from this was what to do about metabolic medicine, because at that time we had the 2 stages of entry, the 2 options for entry. One was from core medical training, which was a 2-year course to do metabolic medicine, and the other was directly from foundation training. We surveyed the fellowship and the trainees, and the majority said that they would like to keep metabolic medicine, and we saw this as an opportunity to expand the entry criteria. This would tick the flexibility box, so we have expanded it to a range of physician specialties, including pediatrics, GP, acute care common STEM, and also broad-based training, which is an option mainly used in Scotland, although not in England, which gives trainees a wider basis of experience, with the option to move then into general medicine or anesthetics. The corollary of this was that we knew that there was no way the COG would accept what was essentially a 7-year training program, 2 years training in medicine or another subject, followed by 5 years chemical pathology, if we also asked them to approve a 5-year training program directly from foundation. They would have told us to take the latter and said that metabolic medicine would have to be moved into credentials. So if we wanted to keep metabolic medicine as an integral part of the discipline, that meant that direct entry had to go. I know this was regretted by some people, and at the time we were actually getting quite good recruitment directly from foundation training, but there was no other alternative. Okay, next slide, please. So this gave us a training program as shown here with 2 years foundation training, 2 years training in a physicianly specialty, and I've put IMT there as an example, followed by 5 years training in chemical pathology, leading to the acquisition of the CCT. And this would be assessed by a medical diploma during the first period of core training, and then FRC Path during specialty training, and also through workplace-based assessments throughout the course of training. And following completion of the CCT, people would continue their medical education through CPD, but they would also have the chance to undertake post-CCT credentialing. And I'll say more about that a little later. Next slide, please. We anticipated that the majority of trainees would continue to come from internal medicine. So I'll say a word about that. Internal medicine training stages 1 to 3 replaced core medical training in August 2019. Core medical training was a 2-year program leading on to 5 years specialist training in subjects such as cardiology and respiratory medicine. IMT is a 3-year, well, the first stage of IMT is a 3-year course leading on to 4 years specialist training. But the 3rd year of IMT is very much targeted towards general internal medicine. And so the medical specialists have been divided into Group 1, where that's relative, such as cardiology, and Group 2, where it's not relevant, such as neurology. And we agreed that chemical pathology should be classed as a Group 2 specialty. We will therefore aim to recruit trainees from the end of IMT2, although if people are struggling with the MRCP, there's an option for them to apply at the end of IMT3. Next slide, please. So we devised the curriculum as a continuation of the IMT curriculum. Rather nicely, this had already been approved, so it gave us a template from which to work. And that curriculum is based on a small number of high-level learning outcomes called Capabilities in Practice, or CiPs, which are all mapped to the GMC's GPC framework. So we adapted this. We continued the 6 generic CiPs. They are a straight continuation of the IMT curriculum. And then we have 5 specialty CiPs, which are a mixture of laboratory and clinical capabilities. And then the curriculum goes on to list areas of study, and then the details of those areas are given in an appendix. This gives us the opportunity to update them in future without having to go through full review of the curriculum again. And they're listed under knowledge, skills, and values and behaviors, which maps nicely to the GPC domains 1 to 3, and they're also mapped to CiPs. Next slide, please. So here are the generic CiPs. The first is about professionalism and also about NHS structure. The second, as you can see, is legal and ethical issues. The third, communication. The fourth, patient safety. And then there are 2 which relate very specifically to GPC domains, research and education. And as you can see, they're all functions that you would expect any doctor to be able to undertake. Next slide, please. The specialty CiPs. The first of these is about laboratory structure and management, and also the analytical knowledge to be able to advise on method selection and appraisal and quality control. The second is essentially about the duty biochemist role, and also writing guidelines and choice of investigational protocols. The third and fourth speak fairly well to themselves. I think the third is about multidisciplinary team working. The fourth is about the consultational role on the wards and over the telephone. And both of them also relate to the multidisciplinary team. The fifth is about the direct clinical care role in outpatients or on the wards, and covers everything that would be covered in metabolic medicine. It rolls up a number of CiPs that were in the Royal College of Physicians curriculum, including care of the dying and outpatient care. Okay, next slide, please. Along with the structure of the curriculum, the content of learning, we needed to think about the assessment of that learning. And that will continue to be based on the ARCP, informed by the Educational Supervisors Report, and it will have inputs from multi-source feedback, from workplace-based assessments, and from examinations. The major changes are in the workplace-based assessments and examinations. So the DOPS, ECEs, and case-based discussions in particular will be in specified areas. Trainees will be asked to do specific assessments during each year to ensure that there is complete coverage of the curriculum as far as possible. The year one examination will be withdrawn. We couldn't find evidence that it was actually predicting performance in the FRC path. We have considered a number of changes to the FRC path, and these have been trailed elsewhere, but the GMC asked for further evidence as to how they would work. And so at the moment they're under review. There's no date for when the FRC path may change, and at the moment it continues as it was. Okay, next slide, please. I should say something about post-CCT credentials. We were specifically asked to suggest areas which would be appropriate for these. Now, the GMC has produced a framework for how these are expected to work, and there are currently 5 pilots being undertaken, which may report later this year. They're in a range of topics: pain management, interventional neuroradiology, cosmetic surgery, community psychiatry, I think, and rural care. The GMC says that these will each need a responsible organisation, and in general it's anticipated that this will be a college or a faculty, but it doesn't have to be. So, for example, the rural care pilot is being led by Health Education Scotland. They will go through a similar assessment process to curricula. The sponsoring organisation will need to make a case for the need for the credential to a COG, and they will then need to develop a curriculum and an assessment process and have this approved by the CAG. We put forward 2 areas. The first was the first was the care of the adult with inherited metabolic disease in tertiary centres, things such as enzyme replacement therapy. And the BIMDG is also interested in this, and it mirrors what is currently happening informally. Internationally, the SSIEM is also interested in drawing up standards for this. And the second area we proposed as a possibility was toxicology. Next slide, please. Coming to implementation, recruitment from foundation training ended in August last year. New trainees starting from next month will commence on the new curriculum. Current trainees will remain on their current curriculum for now, and trainees who have got a CCT date before August next year will remain on their current curriculum and receive their CCT under that. The other trainees, their transition plans should be discussed at their next ARCP. Metabolic medicine trainees will transfer to the new curriculum. Chemical pathology trainees who aren't doing metabolic medicine aren't actually eligible to enter the new curriculum because we wouldn't expect them to have MRCP or another specialist diploma. So they have to transfer to a transitional curriculum. Now that is exactly the same as the new curriculum, with the exception of the clinical content. The clinical content is the same as their current curriculum, although it's written in the format of the new one. And obviously trainees during this coming year may have personal circumstances which lead them to change their plans, and there may need to be flexibility to accommodate that. Next slide, please. So how do we bring this to effect? Well, the first stage is to ensure that that supervisors are familiar with the new curricula and the rough guide to the curriculum, and this meeting is part of that. There was also a post at the ACB national meeting last month, which is still on their website, I think, for a couple of weeks. There will be resources on the JRC PTB and RC Path websites to support local training and self-learning. This meeting, I think, is going to form part of those resources. Trainees will need induction training, and there's a meeting for new trainees in August, to which they should all be encouraged to log on to. And the new curricula will be available on the e-portfolio from August. So thank you very much. I'll now pass you back to Adrian.
Great, thank you very much, Andrew, as I come onto video. Great, thank you very much, Andrew, for that. So I will now talk about capabilities in practice in a bit more detail. Oops, that's going to work. Nora, next slide, please. So there's been a move within postgraduate medical education towards the assessment of educational outcomes. The outcomes of a training program are to produce doctors who are able to demonstrate that they are competent across a range of activities. The concept of entrustable professional activities, or EPAs, is gaining momentum across the globe as a means of determining whether trainees are ready for unsupervised practice. Next slide, please. Capabilities in practice, or CiPs, describe professional tasks or work within the scope of the curriculum. CiPs are based on the format of entrustable professional activities. They utilize professional judgment of appropriately trained expert assessors, i.e. the clinical and educational supervisors. They provide a defensible way of forming global judgments of professional performance. In order to complete training, the doctor must demonstrate that they are capable of unsupervised practice in all CiPs as detailed in the curriculum. Next slide, please. Each CiP is further broken down into descriptors, the expected levels of performance, how the CiP is mapped to the relevant generic professional capabilities, or GPC, the evidence that may be used to inform entrustment decisions. And so to our right is an example of a GPC. So this would be category 2, communication, teamworking, and leadership. And what you see at the top is the descriptors. The GPCs show which domains this all fits under. And then in the bottom, you have the evidence that informs the decision. Next slide, please. Each CIP, as we said before, has a set of descriptors associated with that activity or task. These descriptors indicate the minimum level of knowledge, skills, and attitudes which should be demonstrated. The descriptors are not a comprehensive list, and there are many more examples that would provide equally valid evidence of performance. So here you can see one of the specific CIPs for ChemPath with try to demonstrate the ability to lead and manage a laboratory, to then show what domains of the curriculum are mapped to this, and then actually at the bottom shows even the evidence that can be considered as part of showing that the trainee has met the appropriate level of training. Next slide. Generic CIPs, which is what Andrew has presented before. So 1, able to successfully function within NHS organisational management systems. 2, able to deal with ethical and legal issues related to clinical practice. 3, communicates effectively and is able to share decision making while maintaining appropriate situational awareness, professional behaviour, professional judgment. 4, is focused on patient safety and delivers effective quality improvement in patient care. 5, able to carry out research and manage data appropriately. And 6, acts as a teacher and clinical supervisor. Next slide, please. The specialty CIPs, again, is what Andrew's alluded to before. The first one is able to lead and manage a laboratory. The second is able to use the laboratory service effectively in the investigation, diagnosis, and management of disease. The third, able to manage a multidisciplinary team effectively. The fourth, contributes effectively to the management of medical problems in patients and other specialties. And the fifth, is able to lead and manage a clinical service, including the management of patients in an outpatient clinic, inpatient, ambulatory, or community setting, and the management of long-term conditions. Next slide, please. So one of the key things of how the curriculum is going to be implemented is this business of entrustment levels. So what you will see is at each level, the level descriptors. So level 1 is entrusted to observe only with no execution. Level 2 is entrusted to act with direct supervision. Level 3 is entrusted to act with indirect supervision. And level 4 is entrusted to act unsupervised. So what you see at the top is where the trainee is in training. And this is mapped in this case to the specialty CIPs. So stage 1, and then you have selection into the training. Then you have dedicated chemical pathology training, and at the end, CCT. So at stage 1 training, you can see the levels of entrustment which are required in that stage. Then you follow selection, which is a critical progression point. So this is a fixed point. So at this stage, the trainees have to meet the entry criteria into ChemPath training. Then you have the ChemPath training, ST3, 4, 5, ST6, and 7, with the entrustment levels which have been mapped to the specialty CIPs. So as you can see, by the end of ST7, it should be totally, trainees should be totally able to act, entrusted to act unsupervised. Again, what you'll see there is again another critical progression point between ST5 and ST6 is the completion of FRC Path Part 1. and obviously the final critical progression point is the award of CCT. Next slide, please. There will be 3 key progression points during chemical training, as I've said. First is an entry to the specialty, the second on attainment of FRC Path Part 1 by the end of ST5, and the third of the award of the CCT. Next slide, please. Right, thank you. So at this point, we'll pass you on to Sandra, who will talk about the LEPT platform. Thank you.
Thank you, Adrian. So my name is Sandra Dewar, and I am the assessment manager at the college, and part of my role is to manage the LEPT system. It is the e-portfolio that trainees are required to use during their training. Last year, we started to work on a new platform as the current one is fast becoming outdated. The intention was that all trainees, new and existing, except for those in their final year of training, would use the new LEPT platform starting next month. However, due to the GMC's late approval of the curriculum, only the new trainees coming on board from next month will be using it. The idea was that we would go through a vigorous testing period to involve current trainees, deanery staff, and various other people before its launch. However, there has been a delay to the project, and therefore the full testing cannot happen, not in the way we had envisaged anyway. The new platform will be launched, but as a pilot for trainees starting next month. They will be expected to use the LEPT system in preparation for their ARCP, including completing workplace-based assessments, the MSF, and the ESSR. We don't anticipate too many anomalies or errors with the new platform, but if received, they will be dealt with promptly so that trainees' progress is not unduly hampered. And now I'll hand you back to Adrian for the final slide.
Sorry. Great. Thank you, Sandra. So the next steps. So the curriculum and all supporting documents will be available on the website shortly, along with a copy of this webinar. New trainees will be registering with the RC Path shortly. There'll be a virtual new trainee welcome day, which will be the 20th of August 2021, with details being circulated upon registration with the college. There'll be a webinar about the new curriculum and transition for existing trainees in early 2022. And I believe that's the final slide.